Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rahban, and that's right, we're doing a question and answer, Q&A, and that's correct. This is Maria, my trusty producer, who is with us today, and we're going to be doing a twofer. That's right, one Q&A, particularly curated questions that you guys sent us regarding breast, and the second half, we're going to be doing a follow-up. Maria, I believe it's your fourth month. Yeah, 4-month follow-up on Maria's journey, explantation, reduction, lift. And so it's going to be a fascinating episode. So let's just dive in real quick. As always, you guys have sent us great questions. I'm actually kind of impressed. The questions are getting better and better. I like that because it means you guys are educated and you're listening and you're taking advantage of the content that we put out because the questions are much, much more detail oriented. At any rate, listen to see if your questions are being answered. Who's first?
Okay, the first one comes from L_LuisMe100.
L_LuisMe100, what's your question?
How do you fix gynecomastia and how is that recovery?
Okay, so let's begin by definitions. Gynecomastia is essentially male breast tissue. So 2% of breast cancers occur in men. Men do always have breast tissue, but it's usually quite small and you don't notice it. There are individuals, men, who then have kind of more prominent or extensive amount of breast tissue that presents sort of as man boobs or they look like breasts. It can be a little bit or it can be a lot. The causes of it can be a variety. One of them is smoking pot. It creates an increased amount of estrogen and estrogen leads to expansion of your breast tissue. It can be from being overweight. Overweight creates fat. Fat has estrogen in it. Estrogen leads to man boobs. It can be, in most instances, it's just genetic. I actually am going to be taking care of a father-son. In other words, both of them have it and they're both having the surgery, and it's usually the cause, and sometimes it's hormonal. In other words, there's some element of your hormone system that's off. But nonetheless, the bottom line is that it's essentially prominence of male breasts, and the breast, a male breast, is the same as a woman's breast. It has a component of it which is breast tissue, and it has a component of which is fat, and so it's sort of a combination of fibrous and fatty tissue. So that leads us to the treatment. The treatment is generally one of two things, and it's usually both. It's either liposuction or cutting it out. Now, the liposuction works great when the majority of the breast tissue is fat and mushy. The problem is you can't remove breast tissue with a liposuction cannula. You can't remove muscle with a... It's thicker, it's fibrous. So what generally happens is that's the liposuction. The direct excision or cutting it out is like a mastectomy, but for men. You make an incision in the areola and then you actually remove the breast tissue. So often the procedure is a hybrid. You liposuction, and then you're left with like a golf ball size amount of breast tissue that's left. And then the surgeon will go in and remove that glandular tissue. And the recovery really isn't all that bad. It's basically about a week to 10 days from work or school or whatever, and then about 4 to 6 weeks before you go back to exercise. So it's pretty reasonably tolerated.
Does it happen also when men are overweight and they lose that massive weight and their boobs sag?
So that's a totally different entity because that's not gynecomastia, that's ptosis. That's just skin. And generally, when men who have male breasts lose a tremendous amount of weight, they also lose breast tissue like a woman would. So that usually gets deflated.
Okay, next one is from _Cheryl's Norco.
_Cheryl's Norco? Okay.
What is the best breast cancer screening test after a breast augmentation? Heard mammograms aren't good if you have implants.
All right, so to begin with, the number one screening methodology for breast cancer is still going to be mammography. The only difference is that once you add an implant, your mammographer or your radiologist or the place that you get your mammograms need to know. And pretty much if you're in any major city, there are hundreds of thousands, if not millions of women with implants, so they're familiar. And in addition to the normal number of views, they have to take additional views that are called displacement views. And essentially what they're trying to do is get the implant out of the way.
Yeah, they move it, right. They push you.
Now remember, the implant is not inside the breast tissue. So whether the implant is above or below the muscle, usually below, is not relevant because it's still below the breast tissue. In other words, you have breast tissue, usually the muscle, and then the implant. And so the implant is not sitting inside the breast tissue. So what they do is they literally they push it. I mean, you've had the mammogram with implants.
Mm-hmm.
They crush your breast implant to the side,
And it hurts.
and it hurts, and then they shoot the mammogram through it.
Right.
Now, in addition to that, we have, a lot of other technologies like MRI and things of that nature, which are additional and helpful, ultrasound, but still the gold standard is mammography.
Okay. This one comes from Sveta Kulkin.
Sveta Kulkin.
Why do some people get capsular contracture? Can it be avoided?
Okay, that's a great question. So let's start with definition. What is capsular contracture? So when we place a foreign device within a human being, pacemaker, prosthetic knee, heart valve, IUD, breast implant, your body knows that it's not you. It knows that it's a foreign device. It wants to separate it from you. It does so by creating a shell around it. That shell is a capsule. It is essentially your body creates scar tissue and walls it off. That capsule is normally thin, inconsequential, and irrelevant, and you go live your life. In some individuals, their body tries to do them a favor. And what they do is it creates a really thick and voracious scar, which is then known as capsular contracture. And that scar tissue is not dangerous. It won't kill you. It'll just annoy the shit out of you because it will lead to that breast feeling firm. God, that's odd. My right breast feels so much harder than my left breast. And it will lead to deforming the implant, meaning squeezing it so the implant will sit high and it'll look weird shaped. God, my left breast is really weird looking. So that is capsular contracture. Now, the general population is like 15%. My own in-office rate is somewhere like 3%, so not 0%. So what that tells you is that we as plastic surgeons and the Plastic Surgery Society have not quite yet figured out how to avoid it. But what it also tells you is there's ways to reduce it. So the current theory is that the capsule is triggered by a microscopic amount of bacteria. That bacteria is called biofilm. And that's a very common concept in orthopedics and anywhere there's like foreign stuff in there. And it's a kind of like a little slime. And you can't see it, but you can see it under a microscope. And remember, the breast is not sterile. The breast has bacteria in it. So here are the things that your surgeon ought to do, should be doing 100% of the time. Number one, I used to do the surgery through the areola. I no longer do it through the areola. I do it through the fold. The reason being is when you go through the areola, you are going through the breast tissue to make the pocket. Therefore, the implant is going through the breast tissue to get there, and it's rubbing against more breast tissue. Again, the breast tissue is not sterile. When you go in the fold, you kind of go under the breast tissue. Is it still touching breast tissue? Yes, but not as much. Secondly, we use nipple shields now. We cover the nipples. Why? Because when you squeeze the breast during your procedures, it exudes a little amount of milk or colostrum is actually after babies, but a little bit of fluid.
Right.
And that fluid, if you were to culture it, has a ton of bacteria in it. So we want nipple shields on. That's why you go through the fold and use a nipple shield. Next, you have to irrigate the pocket with lots of antibiotics and betadine. Next, you want to make sure there is no blood when you're done. A lot of surgeons are going through it like bam, 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 fast, super fast, opening the pocket, sticking the implant and get the hell out. Why would you go fast? Because you got 8 of these to do. So when you do it quickly and you don't spend time to cauterize the bleeders, blood is irritating. Irritation leads to capsular contracture. And lastly there's a device called a funnel. A funnel is like a cake funnel. And basically it's this amazing device that a doctor by the name of Dr. Keller came up with. And it allows you to put the implant into the breast without ever touching it. It's called a no-touch technique. You open up this implant in its container, you drop it straight into the funnel, and then the funnel pushes it into the breast. Because your gloves, even though you change them, tend to probably have some bacteria on them. So to answer your question, you can't prevent it, at least we don't know how, but you sure as hell can make it less, and you sure as hell can make it worse.
Well, there's another question regarding capsular contracture from KittyCat0322. Can you fully correct capsular contracture and double bubble? I've never heard of that.
So those are two completely separate issues.
Okay.
So the answer is, can you fully correct capsular contracture? And the answer is yes. When you go back, let's say you present with capsular contracture, the treatment for it is a complete capsulectomy. Okay, so the treatment is to go back in and take that scar tissue out, change the implant because the implant has now been seeded, even though I put it in 3 months ago, and put a new implant in using the techniques I told you. And you should go in through the fold, and you should cover the nipple, and you should avoid blood, and right? And then it usually doesn't come back, but then again, you might get it again. So that's the treatment for capsular contracture. Double bubble is a whole different animal. And so what it is that everybody, every woman who has a breast has a fold. The fold is where the bottom of the breast is. In some people it's low, in some people it's high, in some people it's well formed. But when you look at a breast, there's a nipple, and then below the nipple is the fold. When your fold is short, meaning from your nipple to your fold is not much, and a doctor tries to put in a very large implant, that doctor, instead of making the pocket right up to the fold, so the breast implant is sitting on the fold, goes through the fold, trying to force a big implant in, and then pushes the fold down. Then when you look at the breast, you're looking at the nipple, you're looking at the new fold, and there's a memory of the old fold. So you're seeing two bubbles, the breast bubble and the other bubble, and it's a big complication. It's horrible, and it's very difficult to correct, but it can be corrected. It usually requires downsizing because the implant is too big for your frame, usually. But yeah, that's a double bubble.
Oh. Okay, the next one comes from Wonder Woman.
Wonder Woman, I like that.
Yeah. How long does it take for the breast implants to fall in the right place?
So how long does it take for the breast implants to fall in the right place? So this is kind of a tricky question. So it's called like fluff and puff, or there's this term online that they use. But essentially what happens just globally, the implant goes in, it goes most times under the muscle. And the muscle gets swollen, and as it gets swollen, the implant and the whole thing rises. And so normally, even from a modest breast augmentation, a woman within the first week or 2 or 3 or 4, the implants sit a little bit high. They're a little full, they're a little round, and they're a little stiff. With time being about 3 months, that muscle relaxes, that swelling goes away, and that implant gently starts to slide down and sit into the fold that you and I were just talking about. And the upper pole, the area that was really round, should become a little less round. Now, issues. If your surgeon puts a very large implant in, it ain't never dropping. If you develop capsular contracture, it ain't never dropping. And if your surgeon does a complete under the muscle, meaning doesn't release the muscle, it ain't gonna drop. So the idea of it dropping in the best case scenario usually takes 3 months, but it has to be done correctly.
And how quickly can what's it
Capsular
called?
contracture occur?
Yeah.
It can occur at 6 weeks, 6 months, 6 years, 60 years.
In other words, it can happen at any time.
Anytime, yeah. But generally speaking,
But you feel it.
well, yeah. What'll happen is you're like, wait, my left breast looks a little weird. God, this feels harder than the other side. That's how it goes.
Okay, got it.
And generally, if you make it out of the first year, you're usually out of the woods.
That's good. Elizabeth Groschel is asking how.
Elizabeth who?
Groschel.
Okay, Elizabeth Groschel, okay.
How do you choose the correct profile for breast implants, medium versus high?
Okay, so this is a great question. So the answer is you don't. What do I mean by that? Your surgeon should be the one that's determining these things. And let me explain to you my overall philosophy. We went from, we used to do what's called paternalistic medicine. Paternalistic medicine is you'd go to your doctor and you tell them, hi, I'm here for breast aug. They say, great, I know what you need. I know how big it needs to be. I know, I'm the doctor.
Thank you.
Right, I got this.
Yeah.
And it was a mistake because while they may know the surgery, they don't know what color blue you like.
Right.
They're just telling you what blue they like. And in many instances, people were upset because they're like, well, this isn't what I wanted.
Right.
So we've now switched the pendulum all the way to the other side. And now we practice patient-centric, which means doctors let patients figure everything out. What size, what profile, whatever. And the truth of the matter is they don't know. Why? Because they won't know until it's in their breast at the time of surgery what looks right. But because patients go on Yelp and write negative things and da-da-da, doctors are sort of handing off the baton to the patients because let's say you decided, and I don't know how you decided, or what Mickey Mouse method you decided, that you want a 300 moderate profile implant, and I put that in and you're pissed because it's like, wow, these look big. Whom are we going to blame? You.
Exactly.
Right. So
pass the buck back to
right. So what I tend to do is I don't really let patients make those types of decisions. My wife's spine surgeon didn't ask us what size disc we want in her spine. What I normally do is I have patients tell me what they want to look like, where they want to end up, what's their ideal, what do they like. Then I'll tell them if that's realistic. Then I'll tell them if that's what I agree with. And once we've determined that the end point, that is the thing that they want to do is like this, then I do the rest. And then I determine for them high or moderate and the size. In general, 90% of my implants are moderate, hence the word middle, moderate, and 10% are high. And I use high only in instances where patients are super flat and have no breast tissue. That being said, for a lot of surgeons, they use high because they want to get really big breasts. You get the most bang for your buck.
Well, if you're a big woman as well, if you're tall, you can probably handle.
No, it has a high and moderate has only to do with how much they come forward.
Project out. Okay.
So moderate and high profile refers to projection.
Oh, got it.
You can have a pretty large implant, but it doesn't need to come out so much.
Got it.
Why you pick a high profile in most people's offices is the patient is X wide and they want to get as much breast tissue in that space. And like a lot of strippers or Vegas girls, they tend to have really high profile implants. I'm not a fan of that.
Gary. Okay, this comes from being.cynthia.g. Can you discuss best outcomes for breast implant removal and what to expect and how to prepare?
So we've done a whole bunch of podcasts regarding breast implant removal, BII, breast implant illness, and I'll rehash it for you because it's still a very trending topic. So it depends on why you're removing it. In your instance, for example, we remove your breast implants because you were over the size, they were too big, I had them a long time, my personality has changed. In another woman, they're removing it because they think it's causing them illness. So here are the steps. Number one, you remove the breast implant. The next question is, what do I do with the capsule? Am I going to remove it or not? If your capsule is soft and has no problem with it and you don't have any medical conditions and you feel fine, there is no reason to go through adding more surgery, more bleeding, more whatever when you remove the breast implant because the capsule is your own tissue. If you are a patient who falls under the BII category, I don't feel well, I'm not sure if my implants are causing me illness, the current discussion is that you remove the implant as well as the entire capsule. So you do what's called an en bloc. You remove the implant and the capsule together, okay? Once you've done that, then you need to be prepared. For what? The aftermath. What aftermath? I just removed an implant. There is a cavity, a hole, a space. If you have really large breasts and a small implant, then the impact will be less. If you have very little breast tissue and a very large implant, the impact will be large in that there's going to be a massive deflation. So then you need to determine, do I or don't I, will I or won't I need some type of lift or reconstruction? So it's a complicated discussion that you must have with your surgeon. And if you really want more details, I'd go and check out our podcast on explantation.
Mm-hmm. You know, I have friends that now have seen me with less boobs, and all of a sudden everybody is talking about the explantation. And this one friend of mine she's probably in her early 50s, with menopause, like it happened with me, her breast grew, And so she went to the same surgeon and she took out her implants and put small implants to put more in proportion because
Right.
her breast
Yeah.
grew with the menopause.
Yeah. So two things happen with time. One is you outgrow that style. Like you liked, I don't know, short blonde hair when you were 20 and now you're a more mature woman, so you're not going to have the same hair. So one is I'm not the same person. And the other is that they're just too heavy. So it's a stylistic issue, it's a restrictive issue, and it's very common that as we get older, we change the style of the way we present ourselves. And so while maybe at 30 it was cool or 25 it was cool, maybe not so much at 60. So you just explain it.
Well, the last question we have for this segment is from Not Jazz But Jazz.
Not jazz, but jazz. Okay.
Right? Why do some doctors brag about how fast they do breast augmentations?
It's a fantastic question. For the life of me,
Doesn't make sense.
for the life of me, it makes absolutely no sense why you would brag about being in a rush. What you would make sense is that you make it sound like you spend hours in there laboring when everyone who knows you knows that you don't give a shit. But one thing is for sure, there's never been a mural, never been a Persian carpet, never been a cabinet that's been made or designed that's worth its weight in anything that was done quickly or in a rush.
Right.
You can't even make Thanksgiving dinner quickly. So absolutely, the faster you go when it comes to doing things with your hands, you will do a shittier job because you will be doing less detail, less essential.
You're rushing.
You're rushing. Now, of course, I took 4 days to make my dinner. There is too long, but definitely bragging about doing it quickly. I don't know what it is. I think patients think that speed equates to skill and that if I can do it in 20 minutes, I must be really talented. That idiot took an hour.
Or it could be also that we're in a society of quick satisfaction. They want things done fast. Everything is immediate gratification.
Yeah, I mean, you're going to still get it. The question isn't about immediate gratification. It's a matter of 20 minutes versus an hour.
Yeah.
But the outcome in terms of the aesthetics is significant. So in my humble opinion, it's just crazy. And they'll also sometimes try to make it like, oh, I'm doing it quickly so you're not under anesthesia too long. That's the dumbest thing I've ever heard. That's like saying, it just doesn't make any sense. The risk of 20 more minutes of anesthesia is one millionth the exchange for a shitty outcome, capsular contracture, dead nipple, dead sensation, like asymmetry, like 100 things go wrong when you're in a rush. So it's just a nonsense. The reason why people do fast is because they got to do a lot. And the reason why a surgeon does it quickly is because, as everyone, or maybe everyone doesn't know. So normally the way it works is you pay me $5 for your breast aug. And then I have to pay to use an operating room, and I have to pay to have an anesthesiologist present. I pay for those two items by the minute.
It's by the minute, not by the hour?
No, it's by the minute. That's
Wow.
prorated.
Oh, wow.
So if I do the surgery in 1 hour, I may only keep $3 or $2 of that $5. If I do the surgery in 20 minutes, I'll keep $4.50 of that $5. So let me ask you something. Who's incentivized to be in a rush now? You see where it comes? So the faster I do
always
it,
the money.
Always, as my wife says, follow the money.
Money, follow the money.
All right, let's take a quick break. We're going to take a break, and then we're going to come back, and I guess you have some questions for me.
Yes, about my 4 months.
All right, we're going to take a quick break, and we'll be back, and we're going to then do a follow-up with Maria regarding her 4-month follow-up. See you in a minute. All right, welcome back to the second half of Plastic Surgery Uncensored. We are now going to shift gears. We finished with your questions, and I hope you like the answers. So now we're going to be chatting with Maria, who is now 4 months post-op from explantation, reduction lift. Have I changed your life?
Tremendously.
All right, great. And that is not because we know each other. So what questions do you have for me?
I feel as light as a feather.
All right. So let me give you a quick synopsis of what generally happens. What you should expect around 4 months, and you can confirm if that's the case or not, is number one, pain should be essentially 0. 2, you should be pretty damn active. In other words, I play tennis, I go here, I go there. 3, your scars should be starting to look pretty goddamn good. If they're done correctly, they should be thin, they should be flat, they should be slightly red, but not really anything more. And you should be gaining all the benefits of that surgery. And in that surgery, it should be relief of your shoulders. It should be feeling liberated. It should be feeling lighter because that occurred instantaneously. And your breasts should have consolidated a notch more, meaning, the first 2 weeks they were a little bit swollen, but now they're nice and settled. So what's going on with your follow-up?
Well, like I said, I feel light as a feather. I don't feel I have sleep apnea. I have not been tested again, but I'm sleeping great without a machine, and I'm waking up and I don't have these dark circles that I used to have. When I go train with my trainer every morning, she tells me that, she sees me with more energy, I guess from sleeping better, but that I'm like lighter on my feet, that I'm able to move around and do the exercises well. And I was very cautious because I have a husband who's very mother hen.
Right.
And he would say, do not lift, do not do presses or push-ups. And I said, no. And she's been very careful. She's waiting for this meeting for me to tell her
you're
if she
free.
could do other things.
At 8 weeks you were free, but now for sure you're free. You can do whatever.
My husband wouldn't let me be free.
Yeah, well now it's been caught on camera, so you can tell your husband to watch the show.
Exactly.
So you were free to do everything. The only thing that we tell you to wait a little bit is to lay flat on them.
Yeah.
Like in a massage or chiropractic adjustment, meaning just put all your weight on it. Otherwise, you should be into.
And I wanted to ask you, why is that?
Because at the end of the day, if I were to squeeze your breasts now at 4 months, really squeeze them, you'd be in pain.
Yes.
You would be in pain if you fractured your leg. You'd be in pain if you just had jaw surgery. Because while 4 months is absolutely way better than 4 weeks, you still have sutures inside that are healing. And you want to respect them because I build you a mound internally. And so you just want to give them 6 months for all that to fuse together. It's just letting the last 10% of it heal. Yeah.
Well, I haven't done any of that. So, and you also said no mammogram for a certain amount of time.
6 months, because mammogram, massages, and chiropractic are all about squeezing. So we just don't want it to. We treat them gently for the first couple of months. But you should be kicking ass right now.
Right. Okay. The other question that I had was when you were reviewing my breasts, you said, "Wow, your implants are so low," and I didn't understand what happened there. Why were they so low, and what was the consequence of that being so low?
Well, so what happens is, listen. As surgeons, we have the ability to change some things, and then we have the inability to change other things. So, for example, I cannot change the width of your chest. Doesn't matter who I am, what technique I have, what special. Your breast starts here and ends here. Gail's breast starts here and ends here. In other words, the width of your chest is predicated in advance. So much so that if you got a mastectomy, we removed all your breasts, it would still be the breast began and end here, right? We cannot change where your breast was attached to your frame. So when you look at 100 naked bodies, and we're looking at just the specifics, from the clavicle to the pubis, where your neck starts and where your pubic begins, you have basically essentially 2 types of people. You have a 1/3, 2/3 person and a 50-50 person. So the divide is where your breast ends. So the more desirable aesthetic appearance is 1/3, high breast, long torso, and the maybe less desirable version is long chest, shorter torso. Where your chest was attached to your frame, I cannot change. I can lift your nipple relative to that fold, but I can't move the fold that dramatically. I can put a few stitches in it and changing it, but I can't.
So it wasn't the implants, it was my fold, my natural fold.
Your breast with your implants and everything were low. As a result, you're 5'1", and your chest made up half of your torso. Now, with the breast implant removed and that spring effect, you're going to find that it seems a little higher because what was also dragging it down was the weight. But and so why I say that is, on our earlier part, we talked about double bubble.
Right.
And what happens is the surgeon can come up to and through that fold. And if he or she pushes that fold lower, now you're even lower. And so there are patients where I go to examine them and they put their hands up and their implants are really low, meaning they're right at the fold, and that's not ideal. So I was just mentioning that because you generally had low breasts, period. But they're a little higher today, meaning that recoil went up.
And I remember before doing the breast surgery, I would always, when they would take pictures, I would always notice how low they were. I noticed that.
Yeah.
In pictures, like I felt like my grandmother who had large breasts.
Yeah.
Very maternal, very like, that was one of the things that I didn't like. Now, another thing that you made me do, and I'm saying this and I thought it'd be a good way to kind of tell people what to expect.
Sure, yeah. I mean, you're now 4 months after a very, very popular surgery. Explantation is the hottest thing on facelifts for people in their 50s, and explantation. Those are like the two most hottest topics.
Wherever I go, that they see that I've reduced, they ask me questions. Like, I'll stay half an hour explaining.
Yeah, because
everybody's curious about it.
There was a period in time where augmentation, which is still a wonderful procedure in the right patient, and you happen to be selecting a patient population where, how old are you?
60.
60. So by 60, a lot of people put them in their 30s and 40s, and they're like, either they're sick of them or they were too big. So it's very appropriate for your compatriot, so to speak.
Well, the other question that I had was, you had me select pictures. You told me to look at a bunch of pictures and to select the breast the way that I was. The size. And I will tell you, it was very hard to do because they all look the same to me.
Yeah.
And I had my husband do it.
Okay, it's fine. So let me explain to you what that was
because
about.
I figured he sees my breasts all the time.
So let me tell you what that's about. So as I said to you earlier in the show, what we're trying to do, or what we ought to be doing, what our job is as surgeons, is the same job as a good architect. A good architect, you don't come to a good architect and tell him, I want a kitchen counter that's 48 inches, and tell the architect what you want to a T, because all that architect is doing is building you a piece of shit, ugly house. But that happens to be what you want or what you think you want. That's not a professional. A professional takes your wishes and wants and knows how to ask you questions and then designs you the ideal home based on your needs. But they're still the one who's designing it, because that's the professional. So what I try to do is gather from you enough data so that when you're asleep, I am behaving as your proxy in creating you what I think you wanted. So why I say that to you is, as I told you, one of the biggest elements is we're removing your implants. And what I needed to know was, number one, when I remove the implants, will you be fully hollow? Oh shit, this looks horrible. In which case you and I discussed, put a smaller implant in. I don't want to look ugly. Number two, oh my God, you still have so much breast tissue. So what I needed to know while you were asleep is, what general size do you like, so I can extrapolate? Well, why don't you just tell me I want to be a C? Because I don't know what the hell a C is. You and I went over this. If I went to Victoria's Secret with you right now, we went across to the mall and we picked up 34C, and we picked up 3 of them. Then we went to La Perla. Then we went to Bloomingdale's and we picked up a bunch of 34Cs. They should all be.
They're not the same. 54
inches is 54 inches. Like, doesn't matter if you're in China or you're in Ecuador, it's 54 inches. 106 pounds is 106 pounds. 34C, you might as well have just picked something out of your ass. Yeah. So why I do the photos is because I don't give a shit what that's called. I don't care if that's a 34Q. I don't care if that's a 229. I care you say, hey, Dr. Rahban, when I'm asleep, you see this photo here? I like this. You see this photo here? That's just too big. You see this photo here? It's too small. And then now I have a visual confirmation of what you like, so that when I'm operating on you, I can be your proxy. So the reason I asked you to do that very difficult process is because I'm trying to figure out what you would want if you were awake. Every patient finds it difficult because it's how tall they are, how wide they are. I don't like their nipples. But I can tell you've done this for 18 years. It's incredibly successful for me as your person. You're giving me the information I need. You don't need to worry about it. I got you. So, okay, so that's that.
And the other question I had is why did I have to put tapes around the certain incisions? Not all of them. I didn't have to put the one vertical, but the ones in the bottom and around the nipple. What does that tape do?
So we operate on you. And what is the number one concern for a patient after they get an anchor incision, whether it's a lift or a reduction, literally around your areola, down the middle of your breast, and in the entire fold? What is the number one thing the patient is worried about?
The scar? The
Ugly, horrifying.
Or getting infected?
They don't even give a shit about getting infected. They care about hideous, track, ugly Frankenstein scars. Whether you're a 25-year-old girl getting a reduction, a 42-year-old mom of two with their husband, or a 65-year-old woman, everyone wants to make sure that while the scars, I can tolerate them, I don't want them to be ugly. So naturally, we talked about scars, tummy tuck, facelift, okay, so scars. And I told you, 99% of scars is you and me. You, how you heal. Are you going to make a red scar, a white scar, a brown scar, a thin scar, a thick scar, a flat? You're going to make what you're going to make. And the other half of it is who the hell is closing you? Who's closing you? How are they closing you? How many layers? What type of sutures? How much tension? When they opened you, did they use a blade or they use cautery? There's 1,000 things. So you are you. You're not going to change. Right. And closing in my hands is all me. I mean, the most compulsive closure you've ever seen, as opposed to the tech or another surgeon or a physician assistant or a nurse practitioner or whoever. So you get out, and then everyone wants to know about scar management. What do I do now? Do I use this laser? Do I use this cream? Do I use that tape? So by and large, you're pretty much set into motion. No post-surgical care is going to fix shitty genetics or a hack job. That being said, what I learned many, many years ago, and we learned this from the burn population, who makes the worst scars in the world are burn patients. We learned that pressure tells the cells to flatten. Pressure, if I put pressure on your cells, they literally within the cell send signals and the fibroblasts realign. We know that because when patients get scars from burns, they wear pressure garments. They wear literally like gloves in their faces and whatnot. So when I tape you with paper tape, it's microscopic daily pressure. And all it's doing is putting a tiny amount of pressure morning, noon, and night. It's Chinese water torture. Drop, drop, drop. If I drop water on your forehead after 3 months, I burn a hole through your head. So the idea is a little bit of pressure helps maximize the wound. Well, it's sure as hell I'm going to make a scar.
Well, I can tell you, everybody wants to see it, my scars, and I show them. I go, you can't really tell. And the top part, you can't even tell that it's any type of incision.
And if you were in a marathon, right? A marathon, you're mile 8. You're at 4 months. I would never, and you look so spectacular now. I wish we could show someone. You're not even close to being healed. 18 months is the first time you should be like, ta-da! Because that's like, get the cake out of the oven and now let's taste it. You're like, you put it in the oven like 6 minutes ago. And just imagine what it's going to look like at 18 months if it looks like it does now.
Yeah. The only one is the bottom where the crease is. And that I think is because of the fold. I mean,
it takes time.
It takes time.
Listen, around the areola and down, the one everyone worries about, because like when you're standing there,
and you can't tell.
Right. So within time, no one will be able to tell. And I think that, while it wasn't high on your list, I assure you, I promise you, if you were as light as you are now, felt as good as you felt as you did, and you had ugly, horrible scars, you would not be happy. It would rain on your parade.
Yeah. especially because my husband would see that. all the
Yeah, well,
time.
obviously a big part
Yeah,
about it is
yeah.
the intimacy of oneself with whoever their loved one is.
Yeah.
I mean, the scars bother, my wife happens to be more, like she had spine surgery. I don't even see her scars, but it bothers her. But most people are more worried about their loved ones.
Yeah. Well, my husband, the only thing he can say is, that's exactly how when I met you, that's how your breasts were. And I go, oh, that's good.
Okay, good. Well, we're glad that we reunited you to your
to my past.
To your past, yes. We've rekindled the youth and the love. I'll be there for your second matrimony with him. You guys should get remarried just because of your breast.
Oh, yeah. I got it. Well, by the way, I put on my wedding dress.
And
Fits perfect.
there you have it, ladies and gentlemen. You heard it here first. You get an explant lift reduction, and you can get into your your old wedding guest. Okay, those are big statements. All right, well, that wraps up another fantastic episode of Plastic Surgery Uncensored. Number one, kudos to all of you. Your questions, keep them coming in through social media. I think the questions are awesome, and I'm sure that we're answering questions that a lot of people have. Secondly, if you like our show, if you're enjoying it, go write something nice. Go write a review. It makes a big difference. People are behind the scenes putting in a lot of energy, and it really makes everyone motivated to keep going. Lastly, share the damn podcast with people you love. You think you know that they would or wouldn't do it. You think they're going to come and tell you, hey, could you? They're not. You're going to find out after it's late that your sister, your cousin, your whoever went and got something done, and you're going to wish you had told them to listen to one of our episodes. So spread the information. All right, Maria, until next time, are you going to flash everyone at 18 months?
No.
Okay. All right. At any rate, that wraps up another episode of Plastic Surgery Uncensored. As always, I'm your host. I'll see you next week.